Honorable Vice Chancellor, Professor Mohanan Kundumal Sir, respected Dean, Dental Sciences, Professor L.B. Peter Sir, all the respected faculty members, postgraduate students from the length and breadth of the country. We are extremely happy to initiate the series on recent advances in dental sciences in a webinar mode. Today's topic is oral medicine and radiology and optical spectrometric techniques for early detection of oral precancers by Professor Ravikiran Ongole. Sir is from the Manipal College of Dental Sciences, Mangalore. And we welcome all of you, heartily welcome all of you to this series, which will be repeated on Wednesdays in the coming 3 weeks more. But the timing will be slightly different. The timing will be 12 to 1. And today there are other series of meetings planned online. Hence, we are preponing it to 10:30. Sir, with a lot of respect, we invite you to inaugurate the series on dental sciences webinars. Thank you, sir.
Morning. Ellavarkkum namaskaram. I'm extremely happy to be a part of this very innovative program, which is being organized by the Kerala University of Health Sciences, a series on the recent advances in dental sciences. And I congratulate Dr. Unnikrishnan as well as Dr. Elbin Peter for organizing this wonderful program. And I welcome Dr. Ravikiran Ongole for being a first orator of this landmark program. In fact, universities are the place where the latest knowledge is disseminated. The knowledge which comes in the journals, even before it comes in the journals, when it comes as a thesis, this knowledge should be spread to the faculty first and subsequently the students. And that's what we are doing here. Now, we are touching upon a very important topic, that is oral cancer. As we all know, the incidence of oral cancer is increasing day by day in the country, in the state, and very often we find that these are diagnosed quite late. And when you diagnose oral cancer late, it results in very difficult surgeries and subsequent problems. So now we have new technology wherein you can diagnose precancerous conditions. In many areas, such new diagnostic devices have come up. For example, being a radiologist, I know how radiology has advanced with the benefit of technology. Earlier, we used to do CT scan, MRI for getting anatomical details, and from the anatomy you diagnose disease. Suppose there is a mass lesion, as per the CT or as per the MRI, you say that there is a mass lesion which could be a malignant or benign. Now the technology has come in such a way that MR spectroscopy can interrogate the cells in the tumor and say that whether it is malignant or not from the spectroscopic details. So it has become a common practice to use MR spectroscopy to interrogate the tumors and then come out with a result, so that very often biopsy may not be required, especially in brain tumors and all. Even without biopsy, we are making a diagnosis. Even breast cancer, now the technology is available by using the spectroscopy, so that because the first changes happen in the molecule, and the molecular, the DNA changes in the DNA, the changes in the nucleus. So these changes by their spectroscopic waves can be picked up by excellent machines. Similarly, now it has been possible to use it in oral malignancy also, spectroscopic techniques and Raman's effect. Raman effect, we all know, Sir C.V. Raman, who discovered spectroscopy and for which he was given Nobel Prize, and he is the first Nobel Prize winner from India. And that Raman effect is being profusely in the diagnosis of various diseases, depending on the spectroscopic features. By the Raman effect, you can assess whether that cell has got abnormality or not, and then you can predict. And it has been said that the accuracy is as high as 90 to 95% if you are using Raman effect, and if you use spectroscopic data and the light emitting spectroscopy, fluoroscopy, so all these things. Of course, this is a specialist area, and we have Dr. Ravikiran Ongole to speak in depth about all these areas. So I am not touching upon it. I once again welcome Dr. Ravikiran Ongole, and also I congratulate my colleagues, Dr. Unnikrishnan and LB Peter, and all those who are associated with this. And I welcome each and every faculty who have joined this program. And with these few words, I declare this program, the program on recent advances, the series of programs on the recent advances in dental specialties inaugurated, and you will have multiple such programs. And also this is the beginning. We will have it on medical science, we will have in pharmaceutical science, we will have in nursing science, in every area, the recent advances, the latest knowledge must percolate to the faculty and subsequently to the students. So thank you very much. Namaste.
Thank you very much, sir, for inaugurating this series. It was a great privilege for us to have a radiologist like you inaugurating the series. Thank you very much, sir, once again. Over to Professor LB Peter. Sir, please introduce our speaker.
Good morning to one and all. Honorable Vice Chancellor of Kerala University of Health Sciences, Dr. Mohanan Kuthmel, sir. The officials of Kerala University of Health Sciences, Pro Vice Chancellor, the Registrar, Controller of Examination, the Director of Academic Staff College, Dr. Unnikrishnan, sir. The Chief Resource Person, Dr. Ravikiran Ongole, and Dr. Nilina. Esteemed senior faculty members, researchers, clinicians, junior and senior residents, and all participants who have joined for this webinar. It is indeed a proud moment for the Faculty of Dental Sciences to organize and present a webinar of this kind under the initiative of Academic Staff College of Kerala University of Health Sciences. Until now, we have been conducting programs focused on enriching and refining teaching methodologies and skills for the faculty members under Kerala University of Health Sciences. Today, as our Honorable Vice Chancellor mentioned, we are moving into a very important segment, knowledge enhancement, particularly regarding recent developments in each specialty delivered by eminent resource persons from across the globe.
കല്യാണ ഫോട്ടോ കുറിച്ചെടുത്തിട്ടുണ്ട് കേട്ടോ. ഫസ്റ്റത്തെ റെക്കോർഡ് എന്ന് പറയുന്നത് ഇന്ത്യൻ ക്രിയേറ്ററിന്റെ കയ്യിൽ നിന്ന് വരുന്ന ഏറ്റവും കൂടുതൽ ലൈക്സ് കിട്ടിയ ഒരു ഫോട്ടോ ആയിരുന്നു അത്. 27.3 ബില്യൺ. രണ്ടാമത്തെ
Dr. Anil Paul, please mute yourself. Thank you.
ഫോട്ടോയ്ക്ക് കിട്ടി.
I sincerely appreciate and thank our Honorable Vice Chancellor, sir, for permitting us to kickstart this series of webinars. I also extend my heartfelt thanks and gratitude to all the authorities of Kerala University of Health Sciences, especially the Director of Academic Staff College, Dr. Unnikrishnan, sir, and his dedicated team for their constant support. My sincere appreciation goes to today's distinguished resource person, Dr. Ravikiran Ongole, Professor and Head of Department at MCOTS Mangalore, for graciously accepting our invitation and sharing his experience with us. I also extend my heartfelt thanks to the UG and the PG board chairman and members for their valuable support, as well as to other resource persons who have agreed to deliver future presentations in this series. Finally, sincere thanks to all participants who have joined us today in large numbers. Wish you all a productive session and happy learning, and have a wonderful day ahead. So, now I invite Dr. Nilina and Dr. Divya KD for introducing our chief resource person today for the program.
Thank you, sir. Today's speaker, Dr. Ravikiran Ongole. He has earned his master's degree in the specialty of oral medicine and radiology from Manipal University in the year 2002. Ever since, he has been pursuing his passion for teaching. He has authored 2 books in oral medicine and radiology and is on the advisory board for the first South Asia edition of the textbook of oral radiology, edited by White and Furrow. He has been invited to speak at various CMEs and international conferences. Notable among them was a symposium speaker at the International Association of Dental Research and American Association of Dental Research meeting at Boston, and keynote speaker at the Royal College of Surgeons in Ireland. Apart from his interest in teaching, he is actively involved in the funded international collaborative research projects dealing with the prevention, detection, and medical management of oral precancers. He holds 5 patents and also won various innovation awards. He is the CEO and co-founder of Acadentia Solutions Private Limited, which hosts the popular web portal academicalerts.org. At the university, Dr. Ravikiran heads the innovation and entrepreneurship vertical. He is also the member of the institution's scientific and ethics committee and also the coordinator for the Innovation Center. He is on the editorial board of the BMC Oral Health and the section editor for the Manipal Journal of Medical Sciences. Dr. Ongole is currently serving as professor and PhD guide at Manipal College of Dental Sciences, Mangalore. I invite you, sir, and we are thrilled to listen to your enlightening speech. And now the platform is yours. Thank you, sir.
Thank you, Dr. Divya, for that very kind introduction. Hope I'm audible and visible as well.
Yes, sir, you're audible, sir. Yes.
Thank you so much, Dr. Vidya. At the outset, I really deem it an excellent opportunity to interact with all my fellow colleagues. Special thanks to the Kerala University of Health Sciences. I think it's a wonderful initiative to have these series of webinars where one could actually interact and learn what's happening around the country specifically. I also personally would like to thank Dr. Nilina, who's instrumental in inviting me. Thank you so much, ma'am. And also thank Dr. L.B. Peter for this opportunity again. What I would do right now is maybe share my slide. Dr. Divya, please let me know if the slides are visible.
Sure, sir.
Is the slide visible, Dr. Divya?
Yes, sir. Your slide is visible, sir. Yes.
Okay. And full screen as well?
Yes, sir. It's full screen.
Okay, great. So I would so thank all the participants for joining in today. I would take about, say, 45 odd minutes. The whole idea when Dr. Nilina spoke to me saying, I'd rather want you to speak to all the colleagues here on latest advances. I said I'd like to share my own personal experience and also look at where we are headed with respect to oral cancers, because oral cancers have been very close to my heart. I'm trying to understand how, as oral medicine physicians, can we maybe contribute a small effort towards diagnosing these patients early. So I chose to speak about optical spectroscopic techniques. I understand that there are multiple other techniques available today across the world that can detect cancers early. This is one small effort that we've been working on. This is almost like from the year 2000, I should say, and this is in not just one person's effort, but it's a group of people. We're a big team working towards this endeavor, and the last, I should say, 25, 26 years now. So I will go through all that experience that we have, and hopefully we'll also understand how collaborative efforts can make a small difference. Maybe we'll also discuss a little towards the end as to what could be areas that we can look at, that we can all contribute towards probably minimizing the amount of patient load that we have, with respect to oral cancer. So to begin with, if we look at the pictures that I have, we all know, we know oral cancer, India is the oral cancer capital of the world. We know the oral cavity is susceptible to a lot of insults, especially because of deleterious habits. But do we have solutions? Can we detect early? The question still is, can we detect early? We all know the outcomes are much better if cancer can be detected early. But question is, how early? We all know it has to be detected early. And that's the question, like again, repeat, is how early can we detect? The easiest, I think, would be is to create awareness. And it's a big challenge to tell people how bad habits of either gutka or betel quid chewing is and what it can cause to the oral cavity. That is a part of awareness. I should say we all have a multi-pronged approach. We need to use just not one way, but multiple ways of combating this menace. The other is also a good, thorough clinical examination. Every single graduate, either in the dental school or the medical school, should be trained as a routine to check for the oral cavity, irrespective of there's a habit or no habit. Everybody should be trained to examine the oral cavity thoroughly, very thoroughly. There are, of course, very newer modalities. Everybody's heard of these modalities called Wellscope and Visilite. But if you have to actually look at the pictures that I put up, you have a picture of the tongue there, the dorsum of the tongue, showing you a small, tiny red area that looks pretty suspicious. And a fluorescent image, if I have to call it, on the right-hand side, probably using Wellscope, which is visually and light scope. And that will tell you that the lesion looks a little abnormal, so why don't we biopsy? And that's a standard process. Similarly, there's Visilite that's also looking at use of blue light and use of acetic acid 1%. You apply acetic acid 1% and use this special LED blue color light, and you see the image fluoresce. So what somebody is actually employing here is tissue autofluorescence. You're actually employing the fluorescence of the tissue to show you these abnormal areas. But if you actually listen to me very closely and carefully, every single time I spoke about looking at the lesion on the tongue or that white patch on the lateral margins of the tongue or the tip of the tongue, you had to see a morphologically altered tissue. You have to see something is wrong initially. That's where that thorough clinical examination is important. So please remember this. Every system in place today is always looking at lesions that are already seen in the mouth. You have to see something and then you confirm it with a biopsy. Okay, let's look at that for some time. And now going back to this thorough clinical examination, I'm sure many of you are aware, I think about 2016 or 17, the government of India came up with a very robust plan of breast self-examination in young women age of 20 and above. And because there were very high rates of breast cancer, and that created a lot of awareness. And now every woman is encouraged over 20 years of age to do at least a monthly examination of the breast and to check for lumps in the breast. And that literally brought down most or rather a lot of awareness where people actually are going in for mammography. And I wish there was something like that with regards to propagating an oral self-examination. In fact, the ICMR came up with this kind of a document, I should say, around 2017-18, where they called it oral self-examination. And this is from the ICMR website, where they actually listed out a few things to do. Wash your hands, explore your mouth with your finger. Then they also tell you how to tilt your head back and look at the mouth. Also, if you go down that list, it says feel both sides of the neck for lump or enlarged nodes. But I mean, if you actually look at what's on the left-hand side with due respect to ICMR, many of us know, at least oral physicians know very clearly that the symptoms are much earlier. It could begin off with small, probably burning sensation in the mouth. It could begin with a small, tiny ulcer in the mouth. If you look at what's on the left-hand side, there's no mention of absolutely any ulcer that's non-healing, but they say, do you feel any abnormal thickening? It's pretty vague with regards to how an oral self-examination should be done. So there's a lot more that one can do with regards to protocols for developing how one should really examine the oral cavity. And can you ask 10 questions maybe? Can you develop a simple 10-point questionnaire that begins with, do you chew any of these tobacco products? If the answer is yes, then you go down to the next level and say, does your mouth burn? Do you see an ulcer that does not heal? Do you have a white colored patch in your mouth? Do you see a red color patch in your mouth? Is your mouth opening getting difficult? Along with probably examine, and then you say, go and see a dental surgeon or an oral physician. So I think that there's a lot more lacking with regards to awareness. Now, if you look at this person, we've been doing a lot of work with regards to oral cancer detection. And now this is a very typical 45, 50-year-old lady chewing betel quid. And if you notice, all you see is stains of pan all around the mouth. And where would you put this under? Would you say it's precancerous? Would you say it's habit related, just betel chewers mucosa? Would this turn into cancer? There are a lot of doubts on, would it be ethical to biopsy? What are we biopsying? Where would be the sites for biopsy? Would it really be mandatory to biopsy here, or are just stains in the mouth, like we call it the betel chewers mucosa stains? Is it a precancer condition prior to precancer? So these are some doubts and challenges we all have. How about this patient here? Perfectly looking buccal mucosa. Unlike the previous cases where I showed you a lesion on the tongue, a white patch on the tongue, these are people with habit history, smokers, sometimes even chain smokers. They literally go in every 3 months for scaling, ensuring that teeth look clean. They don't smell of tobacco. But if you notice, look at the buccal mucosa, it's scrupulously clean. So clean, you'd actually feel like there's absolutely nothing wrong at all. Look at the vestibules, they look wonderful except for some recession. The tongue looks absolutely wonderful. But this is the patient who's smoking or chewing. Now, the question is that bigger challenge of, is there a likelihood of this patient developing oral potentially malignant disorder or cancer? How would you answer that question? Would you take a biopsy? For what would you take a biopsy? Because you don't see a lesion. Would you use a well scope? Where would you place the scope? What would you looking at? So these are big questions we have to answer, and this has been troubling me for many, many, many years. What would we do with people who have mouths like this but with habit history? Yes, you can continue following up, but for many, many years, they probably would not even develop cancers. That's that big question that troubled me for quite some time now. So as a postgraduate students in Manipal, these are, like I told you, it's not a single person's effort here, but there are multiple people involved, a big team from MCOTS Manipal, where I studied way back in 2000. And then currently where I work now, MCOTS Mangalore. We also have collaborators from CPCRI, both in Kasaragod and Vitla, which is the Central Plantation Crops Research Institute. They do a lot of work on cocoa, coconut, and areca nut as well. So I'm dealing with scientists from CPCRI and ICAR. And of course, a large of this work is really thankful to the wonderful team from Manipal Institute of Applied Physics, which was earlier called Department of Atomic and Molecular Physics in Manipal. Scientists from there as well. So it's this whole 25, 26-year-old journey has been a team of 4 or 5 different institutes working together towards one very specific objective. Can we detect precancers early? And that's the premise of this talk as well. So to set tone to what I want to speak in the next 30, 35 minutes would be that when I got back to Manipal, when I finished my post-graduation, or rather when I was doing post-graduation, this doubt of literally this whole southern belt, right from, should I say, the coastal belt, right from, say, Kundapur and higher up north, down right up to Kasaragod and Calicut, and down even up to Trivandrum, where I see about right opposite RCC, you have women sitting with tubs of water and areca nut seeds floating in them. It really intrigues me as to, if you look back at Western literature, they talk about areca nut being a single cause of causing oral submucous fibrosis. So that's troubled me for quite some time. I even did very strongly believe OSMF was caused by areca nut until I went to a farm in, should I say, a place called Vittala, where you had all these areca nut plantations, where you had people, the laborers working there. The areca nut needs to be the mature nuts about, say, 10, 12 months. The people who are very skillful. They actually climb up this areca nut tall tree and pluck the whole, the bunch of nuts from there. And they have this unique feature of swinging on from one tree to another. They don't really literally climb down, but swing from one tree to the other. And I was surprised to see one of their requirements is, apart from the wages that they get to pluck areca nuts, they asked the landowner that they should be allowed to chew on these tender nuts. They literally dehusk them and keep chewing. I believe it reduces appetite as well. So one of the requirements is they should be allowed to eat as much as areca nut they want to as they're doing this job over a couple of weeks. Honestly, I was surprised to see not a single areca chewer there who's doing this job has oral submucous fibrosis or any of its symptoms. And that was a trigger that literally began this whole exercise of looking at areca nuts a little differently. And that's where this journey begins. And now we'll set tone to rest of the lecture. We're looking at where this led us to. So I was looking basically seeking just two answers. Still going back to, can we detect oral precancers or cancers early as in really early, in terms of just the habit, but they have no lesions in the mouth at all. And that's the stage we want to see. Not even a small precancer, but a normal looking mucosa. That's the question. And the second bigger challenge was, is areca nut carcinogenic? In fact, for people who are really aware and following up with cancer studies, tobacco, we all know, has been listed as one of the carcinogens, which I strongly believe is. Way back in around 2012, if I'm not mistaken, or 10, the IARC monograph also listed areca nut as a carcinogen. So these were two questions. After I saw these people without OSMF, I was really wondering that does areca nut really have a role to play? So now we are looking at a specific technique. Knowing what the problems are, let's look at some solutions. And just to give you a small basic background of what these optical spectroscopic techniques are. I heard the Vice Chancellor talking of Raman spectroscopy and all other optical spectroscopic techniques, and he's rightly mentioned how useful they are. Exactly. So what we're actually trying to do here is, can we allow light some way to interact with oral tissues or any tissue for that matter? Let light do all the talking. So when you shine light, like in USG where you use sound, we're using now light, we simply let light interact with the structure of the mucosa. Let it interact with it. And when light interacts, it will start to produce some kind of different waves, and we call them spectral signatures. Now, what does this light tell us? It could tell us if the tissue architecture has changed. It can also tell you if the morphology of the cells have changed, or even if some biochemical changes have taken place. It can also tell us about it in different ways and different ways of signatures it produces. So the way this light would talk would be, is either it could get absorbed fully, it could emit, it could also cause some kind of fluorescence or luminescence, and light can get scattered. So if there's some way we can capture all this play of light with tissues, that's where this optical spectroscopy started to take a big role in diagnostic science. They've been using this in different ways, like the Vice Chancellor mentioned earlier. I have no much experience in Raman, though a lot of other colleagues of mine in the Department of Atomic Molecular Physics use Raman a lot for oral cancer detection. But we're using a new technology, a different kind of a technique where we call it LIF, or laser-induced fluorescence. I have used a couple of sort of studies where an atomic absorption spectrometry. It's again a very interesting tool to detect a couple of elements, but it doesn't give multiple elemental detection, but you can detect probably one element at a time. So we'll come to it later. But what I'm going to describe in the next few minutes would be is these experiences with HPLC LIF, then just the LIF in vitro and LIF in vivo when you actually moved it to the mouth, and a newer technique we are trying to use now called LIPS. We'll speak about all these experiences as we go through. Hope I'm audible, ma'am, as of now.
Sir, yes, sir, you're audible.
So I'll go on. I will continue. Thank you. So what we're looking at now is that collaborative effort with all these people I just mentioned earlier. And we're now trying to challenge this whole concept of can we even detect them much more earlier than we're actually seen in the marks. So the first of my experiences started off in the year 2000. It began with my master's program where I had a chance meeting with one of the scientists there, Dr. Karta, who's now retired in Mumbai, a very senior scientist, was working for the Department of Atomic and Molecular Physics, and a student, Mr. Venkatakrishna. So what we looked at is using HPLC. Is literally HPLC has been used for many decades now in pharmacological industries and a lot of pharmacological science, where all HPLC does is it breaks down any sample into its constituents. A good way to segregate material is what HPLC does in very simple terms. So what we did was to collect saliva from a lot of people. We didn't know what we are doing, so we just collected people from different age groups, different from gender differences, from people who were pregnant, people who were menstruating, all different kinds of things. We didn't know what we were headed at, but it was a typical experiment. What we did was to collect saliva, feed saliva into HPLC after the basic preparation of saliva, and then there's a quartz capillary, if you notice there, that so what HPLC did was to break down the saliva into all its protein chains, separating all the protein chains. And the quartz capillary that we used was so thin and fine that it allowed only one molecule to elute at one single time. So imagine a chain of molecules just eluting down this quartz capillary. And this whole length, that the whole time frame was about 30 full minutes. So 30 minutes, saliva in its protein form was simply eluting drop by drop into that quartz capillary. As it was doing, we use an argon laser over 257 nanometer, and this again with multiple experiments, which is the best kind of laser to use at what wavelength. We started to strike the laser at all these protein molecules that were eluting, in the hope that these protein molecules have some of these protein molecules are called fluorophores, as in they fluoresce in the presence of light. So we struck the laser at these protein molecules eluting, and a light was eluted. They started to fluoresce, and that was captured by everything else that you see there. And what came up was this. So that was right at the beginning in 2003. So what you see is, if you actually notice, these are just spectral signatures. And it's so useful that you don't even need to be a scientist. All you're looking at is spectral signature. And if you look at the chromatograms or spectral signatures that we are showing you right at the top of the table, normal saliva samples, you literally see those peaks, or the mountains that we see, the peaks that you see are literally the same kind of shape every single time, irrespective of the top one, that is A, whether it's a female age, male 23, 28 who are pregnant, literally almost the same kind of pattern that keeps coming up. Every single time you see the typical pattern right on top. If you just go down on the left-hand side to graph B, where you see chromatograms of smokers of saliva, just smokers, they have no lesions at all. They're smokers with no lesions of different age groups. And if you notice, some are smoking few, some many more cigarettes. You literally see that vanishing of that normal kind of peaks that are there already. They don't even look like normal. That typical not looking like normal was enough for us to say back in 2003 to say these are abnormal samples. And this was enough to convince a smoker, say, hey, look here, this is how normal saliva should look. These are all your protein peaks. We have not been able to identify all the peaks now, but we know some of them. But we know these are, each of those peaks will tell you one single protein. And if you look at the smokers, those signatures are totally different. And that's a wonderful tool to simply say, hey, there's something going wrong. Maybe, yes, there's some DNA repair happening. A lot of things are happening over time, will happen. But at least at that point of time, the smoker knows there are some biochemical changes that are happening that's not even visible today. Not as leukoplakia, not as smoker's palate, not as nothing. It's normal mucosa, but the spectral signatures are different. And we look at right-hand side, these are samples of pre-malignancy. Those days we call them precancers and pre-malignancies. So if you look at leukoplakia, lichen planus, and OSMF, you literally see these protein molecules behaving super differently. The whole pattern totally exaggerated with different kinds of peaks of proteins that I've seen. And every single, if you look at A, you look at B and C, which is OSMF, every single chromatogram that you see was replicated in every leukoplakia, every lichen planus, every OSMF. So that was a very interesting study at that point of time for 2-3 years, where we said that we now have spectral signatures for every single lesion that seem to be reproducible and replicated. The intensities of the peak could change based on how severe the condition could be, and we could not do that for long. They were like, at that point of time, I would say, I don't recollect now, but about 60, 70 odd samples. And that was literally the beginning of trying to say laser-induced fluorescence can detect cancers, pre-cancers much early than every other technique. That was a good inference that we had in 2003. So that was combining HPLC in a lab and combining laser-induced fluorescence in the lab. So it was something like this. So where you had the laser part of it, and so it was a pretty lab experiment. It's not chairside. Samples of saliva need to be taken to the lab. So this was typical protein profiles that we got. If you look at the bottom, so one of them we identified saying alpha amylase. So if you notice, compared to normal alpha amylase and pre-malignant, malignant, the peaks are really, really high. And this retained the same kind of patterns every single time. So each of those are specific protein molecules. The goal now is slowly trying to identify, it's a big challenge, but the goal is to identify what each of those proteins are, and then it'll make a huge difference to understanding which proteins are behaving how in each of those precancers or cancers. So this again just to show you that the patterns are pretty similar, recognized as well. If you notice the normal, you don't even see the peaks of those typical profiles, but if you see malignant, they're all blunted and stunted down, some of those proteins there. Yes. And we tried to do the same. We also did the same with blood. After saliva, the next experiment was trying to use blood with the same system of HPLC-LF. And you see some of those very important proteins and enzymes, transferins, human serum albumin, and phosphokinase there. Yeah, all of them at different time elutions. Remember, I told you about 30 odd minutes. So if you see these peaks would continue in those specific fashions. So it was getting a little easier now to start to detect lesions even with serum. So again, expanded spectrum, the signatures continue remain the same. Each of those can be identified as a certain protein profile. So again, just to show you, so that was good experiments with saliva, and then it went on publishing just to let know that HPLC can be used with LIF for diagnosing cancers very early. Over time, we started to say now we were all working in vitro. Now we wanted to go in vivo. We started to develop a probe that can literally now go into the mouth. If you see one of the scientists holding the probe on the buccal mucosa, this was on a huge trolley. Again, not really, I shouldn't say a very typical clinic-based setup, but it can be still moved. It can be still, this was done in the lab, but can be moved chairside. It was not a very elegant looking probe, but we could place the probe on the buccal mucosa and still get those same kind of profiles that we did. So at that point of time, when we used, if you recollect, I said when we used HPLC and LF, we were looking at these protein profiles. Now with the same 325 nanometer laser, what we did now with tissue was mainly looking at two basic components, NADH and collagen. Collagen, like we all know, is part of the connective tissue matrix. And we know in oral cancer, especially squamous cell carcinoma, there's a lot of epithelial proliferation, growth, degradation happening at the level of the connective tissue environment. Yes. So what we did was to place this laser along the buccal mucosa or any site in the buccal mucosa. And now we started to get two interesting spectral features here. We started to look at collagen and NADH being eluted at a certain wavelength. Around the 380, 385 collagen was seen, and a peak at around 440 or so, or 430 odd NADH peak was seen when we started to use 325 nanometer laser on the oral tissue. And you see the depth of penetration about 200 microns. So the theory that we based on with all the other previous studies that we did and along with other publications, we kind of knew now that in typical malignant serum specimens rather, that we started to see the total collagen hardly showed us any kind of a peak that was produced, and NADH was really peaking very, very high. So we see a lot of epithelial proliferation happening at a certain level and a lot of collagen destruction. And now if you look at the probe that we have currently, we could actually, these are the peaks that we get. On the left hand side, you would see collagen and then the NADH, and this is replicated literally at every single site in the mouth. There could be small variations with regard to keratinization and how thick the epithelium is, but otherwise generally the uniformity with regards to NADH and collagen continue to remain. And you see a typical reversal, you see heavy destruction with regards to collagen and NADH when it comes to all the malignant and precancer tissues. So again, we again communicated to people saying, yes, there's a great potential that we can actually start to now use laser-induced fluorescence as a probe in the oral cavity. Over time, this is currently the current version. As we are progressing, I cut off the machine because we don't want to share it at this point of stage. But otherwise, the probe has become more slender, more thinner. It can be fit on a surgical trolley, and we are still working on this with regards to using laser-induced fluorescence. Over how laser can be used to create fluorescence and capture and start to look at various protein profiles, various autofluorescence features of those protein molecules in the tissue, as well as also see how NADH and collagen react to various precancers. So we found a very, very popular tool with regards to laser spectroscopy. That was one part of this problem solved, but still this whole concept of, yeah, we understand that there is some now, as we speak, the probe that we've developed is also being, should I say, upgraded, and we're doing more work on it to get it more patient friendly. It's on a project supported by DST, but that's what we are working on. But the other part of the challenge that we just spoke about is the etiology as well. Remember that question on, does arecanut really cause damage? There's a very, very popular theory about, we all know that arecanut has very high copper level, and then it causes cross-linking, collagen not destroyed, excessive collagen is formed, and then submucosal stiffening. So a lot of things related to copper itself. So they said that whenever copper levels are high, OSMF is very, very common. Though now the question was, where was this high copper coming from? And most Western literature started pointing fingers at arecanut. Arecanut has copper, arecholine, and then copper. That is what causes the upregulation of the lysyl oxidase enzyme, and that's where that whole theory of lysyl oxidase pathway. So that was one theory that's very, very popular as we speak. As oral medicine faculty, I also know this theory, and currently we all believe in this, apart from all other pathogenesis. Now, the untold story of many of you are young researchers, students, colleagues, faculty. There are a lot of other things. I mean, many of us must be aware, but for people who are not aware, it's very interesting to know. You can't just, like, I haven't gone into too much of tobacco, but I commonly put tobacco as an umbrella term, saying tobacco. But arecanut per se, I was surprised to know myself that there are at least, there are many more, but at least 15 varieties of arecanut. There's Mangala, there's Madhura Mangala, there's Sumangala, there's HD, there's the Vitla variety, there's Mohit Nagar, there's plenty of arecanuts. Second, areca nuts mature from about 6 months, and they kind of fully become very, very ripe when they're about 9 months old. That's when most of the areca nuts are harvested. Interestingly, when the areca nuts are very, or should I say, tender, not ripe, tender, this is about 6 months old, they're pretty green in color. If you look at the picture right on top, just to show you how those green areca nuts, the outer husk looks green. At this point of time, it's believed that the antioxidant levels are very, very, very high. And the other bad substances that we talk about, arecoline, guacoline, and guancine, arecaidine, all these are very, very low. But as the nuts mature, it's believed that the antioxidant levels fall and the so-called bad things that we talk about, arecoline, increase in concentration. That's, again, lot discussed many a times. The consumption practices also are very unique about areca nut. I, for one, know in Thailand, the husk is eaten. They don't even chew the nut, they chew on the husk. That was very interesting to understand that. And also Thailand, there are a lot of OSMF patients, but surprisingly, the more popular chewing type is chewing on the husk. Whereas in India, nobody uses the husk. They actually use the fruit or the nut, the seed inside, which is the areca nut. In North India, if you go right up to Northeast, up to Sikkim and Nagaland, I know, again, I've heard, I have met a couple of scientists who tell me that areca nuts are plucked, the ground is dug, and all these areca nuts are actually buried underground and covered with mud for a couple of weeks. The nuts, along with the husk, undergo really a lot of fermentation. I believe it smells like crazy when they open it up after a couple of weeks. And then it's dehusked, and then the nut is eaten. Nobody really knows what's actually happening there. But again, they have loads of OSMF, and cancers are very, very high in Northeast India, especially Northeast region. I'm not again aware, but I know of, I'm not aware if many of you are aware in this part of, especially Kerala, where when my wife was doing her observership in RCC Trivandrum, one of the walks on that road near RCC Trivandrum, I literally saw women, I think I told right at the beginning of this lecture, I saw women literally sitting with tubs of multiple plastic or steel tubs and filled with water, and you had these yellow colored nuts floating in. The yellow colored nuts are the typical ripe nuts. It's about 9 months old. They're literally letting them sit in the water. And you have a lot of froth, and it looks very white. The water looks very dirty. It smells very bad. But I believe, I mean, I've seen people actually sit in front of these women like we sit for barber shops in the old days on the road. They sit in front of these women. The women help them peel this whole husk and give them a nut to chew. So that's again, this nut is totally fermented, and I don't know what stage of fermentation it is in, but seems like the same things happening in the Northeast. So that's another practice that we are talking about. So when we say areca nut is bad, are we talking of which variety of areca nut are we talking about? If areca nut is bad, is it in month 6 it's bad, month 7 it's bad, month 9 it's bad? If areca nuts are bad, are we talking of the nuts that are just eaten? Are we talking of areca nuts that are buried in the ground? Are we talking of nuts that are soaked in water? Which are bad? And the processing. Some people, like I told you, those people who climb areca nut actually open up the husk and chew the nut. That is the very tender nut. There are also people who use the semi-mature, and it's very interesting where the semi-mature is used, where it is peeled at around 7 odd months or 8 months, I should say. The nuts are cut into half, and they boil these nuts in the water of the previous year. It's called Chogaru in Karnataka. I'm not very sure. I think Kalipak or something like that in Tamil Nadu or Kerala. I'm not very sure of the name. They boil that in that water of the previous year's boiling. So these nuts are all boiled and dried for sale. That's what is that typical. So there are two varieties. One is called a red and a black variety. The red variety is that typical, very tender nut people can just eat. That is what you get on a betel leaf. You also get the black variety on the betel leaf, which is actually a boiled and processed variety. So are we talking of that causes OSMF? Or are we talking of the ripe variety, which is called Charlie, and a lot of other things. And the soil conditions, how bad or good is the soil, because all the nutrients are from the soil. And finally, are we eating the areca nut plain? Are we chewing it as a quid? Quid means you take a betel leaf, put the areca nut pieces, you put tobacco, you put slaked lime, and all that together. Or are you talking of the commercially packaged form? Which of these is bad is a big question and a big challenge. So when all of us look at Western literature today, all the places, everywhere, all through the literature, all through the paper, the manuscript, they talk about betel quid chewing or pan chewing. And then they suddenly talk about areca nut is carcinogenic. So that's the very gray area that we have to actually tread upon and wonder, is it, what are they really talking about? Are they really talking of plain areca chewers? Is plain areca nut bad? Is a bigger question we all have to ask, because all the packaged forms have many additives. And this question, again, we are trying to see if somehow lasers, optical spectroscopy can unravel all these as well. So it began with looking at copper itself as a question. That was in 2008-9, sometime that range. Then we said, let us first take the betel quid and deconstruct it. So we have a betel quid, would have a betel leaf, would have areca nut, would have a lot of other things, slaked lime and everything else. Shockingly, this research showed us that the betel leaf had more copper than areca nut. It is a one-on experiment, a short duration one. We are working on this as we speak, but betel leaf itself seems to have more copper than areca nut. So again, we wonder really, what are we talking about with regards to what has more copper content? And if you notice, the red areca nut in at least our study showed 18.3 parts per million, as is white at 14.9. That's a Charlie. And so if you look at it, each of them had different levels of copper as we speak. And this was just using atomic absorption spectrometry that can only detect one element at a time. You decide the element and you can trace it. So this led us to a wanting to say, okay, I don't want to detect one element, but can I know what all elements are there? And that's a very popular way to detect multiple element analysis, which is very common and popular, called a mass spec. We all heard of ICP, MS, and LS. And so mass spectrometry is again a great tool, but it's a lab tool, very expensive, goes to a tune of almost ₹1 crore if you have to actually invest to get multiple elemental analysis, and very expensive use of mass spec. But yes, in terms of mass elemental analysis, mass spec is considered gold standard. But what we did was to use a technology that went up in the Chandrayaan called LIBS. LIBS is simply laser induced breakdown spectroscopy. For example, if I'm probably seeing a rock that is, you can actually use this technique, say a rock about 100 meters even away, 100 meters, I'm talking about very far away. You can literally point this laser at that rock. It will create plasma. When it creates plasma, you have a lot of these elements that are expressed, and then that is captured to see what kind of elemental expression that you see. So it can help you detect multiple elements in a given sample. So that's what LIBS is all about. So we started to work around with LIBS. So 15, 16, sometime we started initially saying, we just said, let's try with teeth. We began experimenting LIBS with teeth, and we found a lot of elements expressed there. And we said, okay, it seems to have a good forensic use as well. But since we are talking of cancers, we'll go there now. We did the same experiment, getting various betel leaves from different regions, and we used laser spectroscopy, that's what we're talking about today, in terms of LIBS, where we use the laser and detect elements that were there in the betel leaf. Very surprisingly, we found that copper was there in many of copper was found in multiple samples that we had of betel leaves. And again, if just to
Dr.
Just to
Manisha, thank you.
Just to put things into perspective, if you recollect a slide where I said, if you're saying areca nut is bad, have you actually looked at the soil that it was grown in? Similarly, when we took betel leaves from various sites in Karnataka, about 6-7 sites from different places in Karnataka, we found each of those leaves behave differently. So we have a lot to think about as to what's the soil condition. So can we actually not say areca nut is bad? Instead of saying areca nut may be very harmful, we can probably say maybe regions with this soil content may not be the ideal way of growing areca nut, or maybe areca nuts grown with this kind of soil content may have higher elemental composition, maybe higher copper in this specific region. So these are things that we need to really minutely look at rather than just blanket statement of is areca nut really bad. So that's what we use with regards to betel leaves per se. We did the same kind of experiment using commercially packaged forms of tobacco, which is now gutka, which is banned now, though it's available in many places in India still. We picked up very popular varieties of commercially packaged forms of tobacco and looked at their elemental composition. We're surprised to see a couple of them had carcinogens like chromium as well, aluminum in very high concentrations in some, nickel in some. So it definitely told us something new about what were there in all these commercially packaged forms just by using laser spectroscopy as well. So that's quickly on it. We also started to look at this. I'm just trying to again give a lot of examples where lasers or optical spectroscopy can be used for looking at etiology of cancers here. So we look at that green color nut there. That's on the 4th month of areca nut sample, the 5th month, and as it starts to mature, it turns more yellow. We started to look at do elemental compositions vary, and yes, we found a lot of. That's the setup on the right hand side for the laser breakdown spectroscopy, laser induced breakdown spectroscopy. You look at all the elements that are eluted at different time frames. Now, mind you again, if you notice element number 2, copper, you can actually see copper, though I told you copper, which area. I've been telling a lot about copper here. And what we did with this very specific, interesting experiment was we literally picked one single tree in the campus of CPCRI and literally took care of the tree from month 4 to month 9 and 10 and 11, and waited every month and went to that specific tree which had the same amount of same kind of soil conditions, same kind of climatic conditions, same fertilizers, same fungicides, same fertilizers used, and we plucked the nut from the same bunch of that nuts and studied them across the months. So for that specific tree, we found there was copper content, but if you notice, it started to vary differently. Initially, it was more than as we moved down to the month of 9, which is Charlie, seemed copper being high. But it's very interesting here. I would like to again comment here. If you notice, 4th month or 5th month had very high copper, 5915. And that is in terms of intensity. There's no specific value. Just look at what is the intensity of the peak. And if you go back to that story I told you where these climbers who pluck and chew very tender nuts, none of them had OSMF. And here you're saying they have very high copper with the nuts they're eating. We have to again go back and really relook at all that we're talking about copper and its role in causing fibrosis and OSMF and everything else. Okay. So what we actually expressed was that the study is only this particular variety had very high aluminum copper. We are not very sure. So we need to literally check soil, water, fertilizers, and everything else we talk with regards to areca palm and the nuts. So should I say the end of all this story began with a new beginning was when the central government sanctioned close to 10 crores to study now. I'm not sure if any of you are aware, but now a new study is ongoing. I'm happy to be a part of it, where we're actually looking at areca nut and human health. This is a sanctioned project. And there are multiple teams, about 10 teams studying, do really areca nuts, do they have a role in human health? And there are multiple objectives in these study groups. And our group is again going to focus on using laser spectroscopy, and multiple experiments are underway as we speak. That's about areca nut human health. So to conclude, I hope I gave enough perspective on how we can utilize optical spectroscopy. It has great role to play with regards to the typical, when I say early diagnostic tool for cancer. And it seems to be very, very useful tool. And our vision and hope is that over time we would probably replace biopsies. It would be a very non-invasive way of looking at, and probably a point where people just walk in, like how you have these typical annual health checkups for cardiac care. You would actually go to a corporate hospital and go for a evaluation of the oral cavity. This guy might be a smoker, a chewer, and the optical spectroscopic technique would tell you, no, the mucosa looks okay today. So that's where we're looking at. I really like to acknowledge this whole big team. This is a huge team effort, just not one man show here. Especially Dr. Kartar, Dr. Santosh, and senior scientists, professors there, Dr. Ajit Kumar Patil and Unikrishnan is working with me currently. From the CPCRI group, Dr. Hebbar is a director and Dr. Nagaraj is senior scientist again. And we have a huge team from MCOTS Mangalore, maxillofacial surgeons working with us, and all my postgraduate students, PhDs, and every single person is part of this journey. Before I actually conclude, I brought this up earlier. I know this is not absolutely a scope for this lecture, but since you're talking of recent advances, and somebody, Dr. Divya introduced me right at the beginning saying I'm CEO. It sounds a little out of place, like a CEO of a company, but what we actually did, and the reason why I'm using this platform very unannounced to talk about this is because even the other day, a couple of 2-3 days ago, I remember seeing somewhere in one of our WhatsApp groups, somebody putting up saying, I'm invited speaker to a conference and I'm glad to be a part of this oral cancer conference. I'm keynote speaker. There are many, many, many predatory conferences happening all across the world. Predatory, like we have predatory journals, they have predatory conferences. So as a give back to the academic community, this is a free use website. All of you sitting here, I would urge you to simply go back to academicalerts.org. If you're there, you can actually scan this or just go to the website. You can be a part of the community. It's free for use. And literally you'll see that there are at least 1,200, 300 odd conferences listed there today. And all of them are genuine. And this is again the first of time where we don't have a single website that displays conferences across all disciplines, from health to technology to management and everything else. So I'm assuming this could be a part of the umbrella of recent advances as well. So thank you all so much. And if you have any doubts, you can always write back to me, keep in touch with me. Hopefully we'll be able to expand this research using optical tools on Arecanut. Anybody's keen to work on Arecanut, I'd be more than happy to discuss things with you all. Thank you all so much. And thank you for the opportunity, Dr. Neelina, Dr. LB, and Dr. Divya. Thank you again for that introduction. Thank you all.
Thank you, sir. Thank you so much. We had a really enthralling journey with your real life experiences and experiments with regard to the liquid chromatography, optical spectroscopy, and it was real life experiences, and we could see really the efforts you have given to bring forth such an valuable knowledge to all of us. So thank you so much for this enlightening presentation, sir. We can take 2 or 3 questions based on this presentation. So participants and dear faculty members, if any doubt is there, can you please put forth those in the chat box so I could bring on the discussion? Or you can even please unmute yourself and ask the questions if at all any is there.
Good morning, all.
Yes, sir.
Yeah, actually, it's a great beginning to a nice innovative activity by TUHS. Thanks for that, first of all. And is it possible to have these resources for a valuable diagnostic tool in all dental colleges, dental institutions, financial wise, no? Because we'll be able to say it better? Is it easy to have, or is it really difficult to have? Or do you need trained person for that? Or even a regular staff can get trained?
So,
Well,
Dr. Yes, I
yeah,
can
thank
answer
you.
that. Yes,
Yeah,
yeah. If I can answer that, Dr.
yeah,
Murli,
sure,
thank you.
sure, sure. Sure.
Yes, thank you for that question. So I would think ultimately it's just that first is the willingness to work. It's very laborious.
Okay.
Yes. Now with regards to the expenses involved, all these are I should say very much assembled. You need probably people in teams of say people who have some experience in laser spectroscopy itself. Otherwise, it's more to do with a very experimental. You buy a spectrometer, you buy chromatographs, you actually literally assemble this. The expenses are huge in terms of initial investments because, and all of these, every single thing I mentioned to you are supported by grants. It would be pretty expensive to assemble them together because all those equipment that I spoke about are not cannot be readily purchased, especially the spectrograph and lasers have to be imported. They're expensive. I don't know if you can put a value on it, but otherwise, yes, you need trained personnel who are well
Yes.
versed in physics of optics. You also need grants to get these equipment. However, the outcome of this, what we see is probably, I'm hopeful that we'll all be able to maybe develop something that we can use as a chair side tool. If you notice, the last thing that is masked was maybe a optical tool that we would definitely be able to make it much cheaper because a well scope today would cost about $2,000 in the market, which people are just selling
Okay.
it. And again, to put a perspective on Wellscope, I know couple of institutions have bought Wellscope, but I mean, I have nothing against Wellscope, but I would very personally, call it a glorified toluidine blue, if I can call it,
Okay. Got it,
because
got it, got it.
what you see is a white patch, and you place it there, and then you'll tell the surgeon, "Hey, this is where you need a biopsy from," right? You could just do it
Okay.
with 10 rupees toluidine blue. So
Okay.
you don't need to probably spend $2,000 on something like that. So what we are looking at is to make it something more affordable that we can all use on a chair side. That's the plan. But hopefully in some more years that would materialize, I would think.
Thank you. Thank you so much, sir. That is one thing.
Thank you, Dr. Murali.
Anything.
Sir, we
Thank you,
have
ma'am.
one
Thank you.
more question in the chat box. Dr. Sanhita has asked that which are the three most common causes of oral mucosal lesions? I'm sorry, the three most common oral mucosal lesions caused due to arecanut in Karnataka, especially. She wants to know.
So yeah, that's the answer is I don't know today if arecanut is causing it, but I can very that's the whole question we're all trying to ask. The government is also asking us, does arecanut cause? Yes. So again, to put that into perspective, this study that was initiated by the government of India about 6-8 months ago, we have already screened about 15,000 people in multiple geographic locations in Karnataka, door to door. I don't want to give exact numbers today, but if I can tell you, we are seeing many beetle quid chewers. Trust me again, there are not many gutka chewers in the interior parts of Karnataka. No gutka chewers. They're all beetle quid chewers. We have not seen a single oral submucous fibrosis case so far. So again, I don't know. I can't tell you if beetle quid or what is causing worsening. Still, I don't know. But arecanut per se seems extremely doubtful. Arecanut cause something that I'm very, because again to put into perspective, we hardly see anybody doing that typical, or rather using pure arecanut. Like I told you, you peel the nut and eat it. We don't see many of those. But what you see is with a combination of slate lime and. So if you have to ask me a question, does arecanut per se, alone arecanut chewing, does it cause oral submucous, does it cause oral mucosal lesion? Maybe not. Maybe the granular structure, maybe the coarseness of arecanut would cause some amount of beetle chewers mucosa, if you want to call it like that. if that could be one of the oral mucosal lesions you're looking at. But yes, quid chewing, not areca nut, but quid chewing, which might also have areca nut and other additives and slake lime and everything else with tobacco, plus gutka chewing, will surely cause some amount of a mucosal change that would probably turn dysplastic. I would leave it there. I don't have evidence, honestly, on what could be the most common mucosal conditions in Karnataka because of areca nut. That's all I know right now.
Thank you, sir. Thank you, Dr. Sanhita, for the question. So I would like to wrap up this meeting now. So thank you, sir. I would move on to the vote of thanks now.
Madam, 1 minute. Can I just put in a word?
Sure. No problem. Ma'am, can you kindly introduce
Yeah.
yourself? Because we can't see your name there.
I'm Dr. Nilofer
Yeah, thank
from
you.
Al-Azhar Dental College. And I would like to thank Dr. Ravikiran Ongole sir for this wonderful session. It has been a very elaborate and useful session, sir. So what I wanted to ask is the current lasers that have been used for treatment, like lasers are available in the market, which is being used for treatment for like implants per se, ulcers, etc. Can we use those lasers in these observationals or probably in detection also? Or, can there be some software analysis that can be added there?
So, ma'am, the kind of lasers that we are using are not in the same wavelength that therapeutic or diagnostic lasers use. Also, the helium cadmium laser and the argon laser that we have been using earlier are not typically diagnostic or therapeutic.
So this cannot be extrapolated. We need a separate set of lasers that you mean.
Absolutely. Yes.
All right. So thank you so much.
Thank you, ma'am. Thank you, sir, for answering the question. So since we are running short of time, I would like to wrap up, and I am going to moving on words towards the vote of thanks. So, respected dignitaries and dear colleagues, and it was my privilege to propose this vote of thanks for today's Academic Council webinar. At the outset, I extend our heartfelt gratitude to Dr. Unikrishnan, our Dean Academic Staff, for delivering the warm and gracious welcome address that set the tone for the session. And we are deeply honored by the presence of our esteemed chief guest, Dr. Mohan Kundumal sir, Honorable Vice Chancellor of Kerala University of Health Sciences. Your inspiring words and your bird's eye view on the topic shows that how visionary a leader you are to guide and strengthen this kind of academic framework of our university. And I sincerely thank Dr. L.B. Peter, Dean Dental Faculty of KUHAS, for his constant encouragement and valuable support towards conducting such webinars. My special appreciation goes to Dr. Nilina R. Kumar, the head of the department and a member of Academic Council and the Board of Undergraduate Studies, for meticulously planning the session and coordinating it. And we are especially grateful to our distinguished speaker, Dr. Ongole sir, for his enlightening and insightful presentation on the topic in oral medicine radiology. Your expertise and clarity have greatly enriched us our understanding and inspired all of us, sir. And I also extend my thanks to all the council members, faculty, fellow participants who joined this meeting and contributed to its success. With sincere gratitude to everyone who made the session meaningful and productive, I conclude this word of thanks. Thank you, sir. Thank you, each and everyone who attended.
Thank you, Dr. Divya. Thank you.
Thank you, Dr. Divya, for wonderfully moderating the session.
Thank you, sir.
So this was our first webinar of the series on recent advances in dentistry. So we could start this topic with Ravikiran Ongole sir. Thank you very much, sir, for sharing your valuable information. And it was a very wonderful presentation, and it was really appreciated. And thank you, sir. Thank you very much. Our sincere thanks to the Honorable Vice Chancellor, as already Dr. Divya had told. Sir had in fact studied the matter in detail, and sir gave a bird's eye view, as you rightly said. And my sincere thanks to Academic Staff College, because Academic Staff College of Kerala University of Health Sciences has sowed the seed for this, and they have initiated this program, and they have scheduled this series for us. And we are having continuous webinars on every Wednesday. For next Wednesday onwards, it is from 12 to 1, and we will share the link for participants to join. And my sincere thanks to the Director of Academic Staff College, Dr. V.V. Unnikrishnan sir, who is constantly behind us in undertaking this type of webinars and academic related activities. Supported by the entire team, Dr. Mercy Madam is right here with me. They all coordinate and does this program for us. And I also sincerely thank the Faculty of Dental Sciences and the Board of Studies PG and UG for their valuable inputs. And my sincere thanks to the Chairman of Board of Studies UG and PG, Dr. Epan Cherian sir and Dr. Baiju sir. Members, Dr. Murli sir is there, Dr. Sudeep sir is there, Dr. Suchitra ma'am is there, senior faculty members are there. Thank you once again for all the support extended to us. And with that, we shall wind off this webinar and we shall see you on next Wednesday at 12 p.m. Thank you.
Thank you all. Thank you.
Thank you all.